All right, everyone, welcome back to our final talk of the day. So I'm happy to introduce Courtney Artridge and Jackie McMillan. Courtney is the project officer at the Women's Health New South Wales, working on a project that focuses on strengthening professional understanding and local capacity to respond to women's experiencing non-fatal strangulation and consensual sexual choking. Courtney's passion and unique understanding of the gendered nature of violence was gained from her work within the international humanitarian aid sector and project implementation in countries suffering from violent conflict, including Iraq and Yemen. Courtney's professional experience expands across a variety of roles, including nursing, security advisor, education officer, and pre-hospital care coordinator. And presenting with Courtney is Jackie McMillan, who is a Senior Project Officer at Women's Health New South Wales, working on a project creating pathways for women experiencing non-fatal strangulation, sexual choking, and acquired brain injuries. This role harnesses her commitment to ending violence against women, honed during her time at Australia's National Research Organisation for Women's Safety, with her experience in sexual consent and sexual health developed across nearly a decade at the Sex Workers Outreach Project, including time as their board president. So please help me welcome Courtney and Jackie as they present on driving practice change to better support women with experiences of strangulation, sexual choking, and acquired brain injury.
Thank you so much, Kelly. I'll just share our PowerPoint now.
Great. That looks great. Thank you.
Perfect. Okay. So we would like to acknowledge the traditional owners and custodians of the land on which we are coming to you from today and pay our respects to elders past and present. The Women's Health New South Wales office is on Gadigal land, but our work takes place on unceded Aboriginal lands across the state of New South Wales here in Australia. To set the scene for our conversation about strangulation and brain injury, we'll start with a case study from one of the women's health centres we work with. So Opal is a 49-year-old single mother who had been unable to work for several years due to poor mental health. Opal first engaged with Women's Health Northern Rivers as part of the Worth program. This program was designed to support women in the local area after devastating floods in 2022. Through the program, Opal received ongoing counselling. During one of Opal's counselling sessions, she disclosed she had experienced domestic and family violence when living with her ex-husband. Opal said she escaped the violent relationship 15 years ago after her ex-husband burnt the family home down. After this disclosure, and in the very same consult, the counsellor used plain, simple language to screen Opal for strangulation. Opal revealed she had been strangled multiple times by her ex-husband. This led the counsellor to complete a strangulation assessment, including looking at whether Opal had any medical red flags that would indicate a potential brain injury or other long-term health conditions caused by strangulation. The counsellor made a multidisciplinary response that included looking at Opal's safety needs and other short and long-term needs. As part of the assessment, the counsellor used her professional curiosity to find out more about the strangulation events to determine their severity and Opal's risk of brain injury. Opal stated she was strangled multiple times, and her description of what occurred sounded like she lost consciousness on one occasion. Using open-ended questions, the counsellor helped Opal to identify any new or evolving neurological symptoms that had occurred since the event. Together, they found Opal had experienced multiple cognitive, sensory, and physical symptoms, including post-traumatic stress, anxiety, panic symptoms, memory problems, cognitive processing issues, fatigue, visual difficulties, particularly trouble locating objects, chronic pain, balance and mobility issues, and a tight jaw. These symptoms have had a significant impact on Opal's quality of life, and in the previous year contributed to her having a mental health crisis at work. At the same time this assessment was completed, Opal was unemployed and relying on government benefits for her daily living expenses. On the screen, you can see images of the Women's Health New South Wales Strangulation Assessment tool. On the second image, you can see the practitioner instructions in the left column and the results of the assessment in the right column. This assessment tool is available on our website. So, what happened next? The counsellor delivered health promotion designed to encourage help-seeking behaviour. She supported Opal to make the connection between her experiences of strangulation and the current health impacts she was struggling with, even though those experiences occurred over 15 years ago. Opal was supported to discuss her experiences and symptoms with her family doctor, whom she trusted. They filled out a medical referral letter to help Opal communicate what's been going on for her. Opal was also able to access case management and social worker support for further psychosocial assessment. She was supported to have a neurological assessment and treatment by a neurophysiologist. She accessed physiotherapy to address her mobility issues and knee pain. And she accessed occupational therapy to support an application for the disability supports. These services were all free and provided on site at Women's Health Northern Rivers. Opal also felt emboldened to refer herself to an osteopath. Although this was effective, she found it was unaffordable in the long term. Opal also received financial support from Women's Health Northern Rivers, including fuel vouchers to travel when she needed medical scans and gap-free coverage to pay for the scans. Opal found this response validating and felt supported for the first time. However, beyond Women's Health Northern Rivers, the system wasn't really working for Opal. Her biggest concern was her deteriorating health and the possibility of permanent unemployment leading to homelessness. Opal wasn't eligible for financial assistance packages that fall under the Victim Support Scheme here in New South Wales because the violence occurred more than 15 years ago. Her eligibility for the disability support pension was complicated because she didn't yet have a medical diagnosis for a brain injury. A few months after this case study was written, Women's Health Northern Rivers informed us Opal's application for the disability support was finally successful. A major contributing factor for this success was the collaboration between Women's Health Northern Rivers and another local organisation that helped Opal produce a strong application based on her PTS diagnosis rather than her potential brain injury. The financial support gained from her initial application will support Opal as she continues to recover from her abuse. And in the future, it can be expanded to allow her to access the services needed to address the potential brain injury. Now, I'm going to rewind back to the beginning and explain who we are and how we contributed to these positive outcomes for Opal.
So my name is Jackie McMillan, and alongside Courtney, who you've already met, we work at Women's Health New South Wales. We are the peak body for 21 non-government, community-based women's health centres and special purpose services that operate in New South Wales. Each women's health centre that you can see marked on the map offers a range of services that directly respond to the needs of women in their local community. Roughly 60% of our workforce are counsellors, but we also have doctors, nurses, naturopaths, case managers, health promotion officers, massage therapists, to name a few. As a peak body, we do a range of things, including leading capacity building projects and advocacy on key women's health issues. The project that led to Opal's outcomes was called the Pathways Project. It came about when Women's Health New South Wales received a grant of national and state monies to help strengthen professional understanding and local capacity to respond to sexual assault-related non-fatal strangulation and acquired brain injury. To make sure that what we did was evidence-based, we started by mapping the available evidence on strangulation and brain injury. Spoiler alert, there were gaps in the Australian data relating to women's experiences of strangulation and brain injury. You can check out what we did find in the evidence brief that's pictured on the screen, which is also available on our website. One thing the process of mapping the evidence made clear was that while the Pathways project started out solely as a sexual violence project, we weren't going to be able to address sexual assault-related non-fatal strangulation without also addressing strangulation in the context of domestic and family violence and strangulation enacted with consent in a sexual context, commonly called sexual choking. While both strangulation and sexual choking can be mechanisms of injury for brain injuries, we found that we needed to approach these issues differently. So to create sustainable practice change and build workforce capability, we used a two-pronged approach. At our women's health centres, we delivered 3 rounds of face-to-face training. The first training developed the workforce's baseline understanding of strangulation, sexual choking, and brain injury. The second training discussed how research and experts define best practice for responding to these issues and explored what that might look like at each centre. Simultaneously to the training, we supported each site to build robust, multidisciplinary referral pathways that were unique and specific to their local area. These two prongs came together in the final round of training, where we presented the new protocol and referral pathways to our teams, and they practiced using them with case studies and simulations. To make sure that referral pathways were effective and to share knowledge more widely, we also provided free training to external organisations who might encounter women with these experiences in their service provision. This saw us deliver training to police, women's refuge staff, court advocacy services, men's behaviour change professionals, mental health workers, people who work with migrants and refugees, youth workers, sex worker outreach staff, university student wellbeing teams, legal actors, and youth peer leaders. And finally, we created resources that the centres needed, including ones that helped them work with women more effectively, and we shared them more widely on the It Left No Marks website.
Let me start again. We identified 4 key areas our teams needed support in to drive sustainable practice change and improve outcomes for women with experiences of strangulation, sexual choking, and brain injury. They were improving the workforce capacity to screen, supporting the workforce to make a multidisciplinary response, and increasing their ability to deliver health promotion and reinforcing the need to collect data. So we'll go through these in a bit more detail now. And along the way, we'll show you some of the resources we created that you might be able to use too. So the case study we shared earlier shows the first time Opal received support directly related to her experiences of strangulation was 15 years after the incident occurred. The time between experiencing strangulation and receiving help emphasizes the barriers women face in disclosing strangulation and highlights the need to improve workforce capability to screen for strangulation. In our workforce training, we focused on helping service providers recognize that screening is a commonly misunderstood term shrouded in alternative labels and misconceptions. The differences in terminology used by the media, the general public, sector workers, the law, and academics all impact reporting rates, limit the accuracy of screening tools, and impede effective service responses to women. We explained that strangulation sounds very serious. It's the term used in our Crimes Act. This can make victims and survivors choose alternative language to minimize the seriousness of strangulation. Women can also minimize what has occurred because the person who encouraged them to participate in sexual choking is the one setting the discourse. This might be intentional, so a part of coercive control, or it might be because they themselves don't know the risks, so present sexual choking as nothing to worry about or a normal part of sex. An Australian study found that some women do not disclose strangulation because they do not relate their experience with screening questions. A UK study asked the same group of victims and survivors 2 questions. When the women were asked if they'd been strangled, 45% said yes. When the women were asked if they'd been held in a way that meant they couldn't breathe, 75% said yes. Feedback from our training surveys found the most common key message taken from our training was the use of language and better ways to ask questions and screen for strangulation. We instructed our teams to use more benign and general questions about pressure being applied to the neck or being held so you cannot breathe, to help avoid confusion about terminology and potential minimization by victims and survivors. This approach worked. One women's health centre we visited told us they saw very little strangulation, despite their core business being domestic and family violence. However, after our training, they changed the way they asked the question on our state-based DV risk assessment tool. They now ask, was pressure applied to your neck or were you held in a way that made it hard to breathe, even during sex? Women usually start to shake their head until the questioner gets to even during sex, when women usually start to nod yes. 4 months on, one worker we trained at that centre told us that 90% of the clients she sees have experienced strangulation. Key training messages on screening were reinforced in the tailored organisational protocols we built at each site, which provided guidance to practitioners on when to screen and what language to use. All 20 guidelines were co-developed with each women's health centre, and they provided unique guidance to staff on screening that was relevant to the way their centre operated and the various communities they served. For example, some women's health centres chose to implement routine screening for strangulation and sexual choking, while other centres wanted staff to screen if there was indicators of or disclosures of domestic, family and sexual violence. Other centres who had a GP wanted to screen for sexual choking during sexual health checkups. Importantly, data from those centres who did implement routine screening showed disclosures of strangulation occurred in doctor's appointments where the women's presenting issue was cervical screening and sexually transmitted infections. All women's health centres encourage staff to modify the suggested screening question based on the client in front of them. Some examples of this modification included changing the word sex to intimate times to work better with culturally and linguistically diverse women. We supported women making disclosures with the poster you can see on the screen here. Our members used this in their waiting rooms and treatment rooms as a conversation starter.
So, as demonstrated in the Opal case study, strangulation impacts a woman's physical, emotional, mental, and psychosocial health. Other case studies we collected during this project showed the health implications of strangulation, including related brain injuries, impacted the woman's quality of life by limiting their ability to participate in work, complete their studies, make decisions, socialise, leave violent relationships, form healthy relationships, and their overall happiness. While practitioners at the women's health centres were highly skilled in making safety assessments and providing mental health support to women who'd experienced domestic, family and sexual violence, prior to our training, they'd had very little training on the physical impacts of strangulation, including related brain injuries. As one practitioner who had been in the sector for over 30 years said, "I never connected non-fatal strangulation and brain injury before this training session." We helped practitioners recognise the important role that assessments play in the complexities of women's presenting issues after strangulation. We help them deliver a multidisciplinary response through recognising those complexities. We also unpacked how strangulation and sexual choking can both cause a brain injury. As the Australian Women's Health Alliance pointed out, acquired brain injuries are common but underdiagnosed and underreported in women, especially women affected by domestic, family and sexual violence. This is connected to the way that women's brain injury symptoms are often dismissed or wrongly attributed to psychological issues or alcohol and other drug use. Again, particularly in that group of women affected by domestic, family and sexual violence. We used research to support key messages about brain injury, unpacking the differences between a hypoxic brain injury and a traumatic brain injury to explain that strangulation accompanied by head knocks or blows to the head usually results in worse outcomes for the woman. As our workforce doesn't include neurophysiologists or other brain injury specialists, we were not asking anyone to be able to diagnose a brain injury. Instead, we worked with our practitioners to identify how they can support a multidisciplinary response by identifying the woman's needs, knowing the range of services available in their area, and making warm referrals to help the woman address those needs. So, for example, if they identified a historical strangulation event, they would know that there'd been a mechanism of injury for a brain injury and assess for new or evolving neurological symptoms and provide a referral to healthcare for a medical assessment if the woman reported having any. We helped our teams keep a multidisciplinary response in mind by creating statewide guidelines that form the basis of each Women's Health Centre's organisational protocol and referral pathways. The guidelines start with 2 at-a-glance flowcharts, one for strangulation in the context of violence and another for sexual choking. These flowcharts guide the service provider through making a multidisciplinary response. Each Women's Health Centre customised the guidelines to reflect their internal services and the external services available in their local area. The assessment tool that we mentioned earlier in the case study was developed to complement the guidelines. When we were working with individual women's health centres to help them develop their local referral pathways, we learnt that many locations didn't have the services needed to ensure a best practice multidisciplinary response. The lack of brain injury services played into reluctance from some practitioners to even raise brain injury with women with experiences of violence. Some practitioners asked us, what's the point of telling her another bad thing resulting from his violence in the absence of anywhere she can afford or access to get diagnosed or treated? We're going to come back to how we solved that problem a little bit later. Here in New South Wales, we have clinical guidelines for strangulation in the emergency department. These guidelines are geared towards acute injuries. There are no specific guidelines for historical strangulation injuries, so whether these presentations can be addressed in an emergency setting is up to the practices of each hospital. We also found a gap in clinical guidelines relating to sexual choking. Women engaging in sexual choking have different health needs compared to women who've been strangled in the context of violence. We work directly with our state's health lead, New South Wales Health, to get agreement that women who engage in sexual choking don't have the same compounding health needs as women who experience strangulation as a part of violence. This means that acute cases don't always need to be referred to the emergency department. They can be managed by a general practitioner or GP. GPs are the main coordinating points for women's health needs here in Australia. So we spend a lot of time engaging with this group to help ensure that women get a good response when they enter the mainstream health system. GPs are considered private healthcare providers and they're spread out across the state, so they can be a really hard bunch to reach. You can see some of the ways that we did it on the screen. They included having a dedicated page for healthcare providers on our website, collaborating with doctors and emergency room specialists to develop a video for GPs, 3 minutes, that's all they'll watch. We also collaborated with New South Wales Health to make sure our resources were included in health pathways. This is a dedicated online referral pathway for GPs that they can use during clinical consults. We worked with a private education company called Health Ed, who produced resources for GPs to help them maintain their requirements in continuing professional development. Health Ed run trade show style events for doctors where we had stalls and we spoke directly to GPs that attended, as well as we did presentations on their main stage. Health Ed also hosts podcasts for doctors who prefer to do their learning and development at their own pace. We managed to have 5 podcasts published covering sexual violence, domestic and family violence, and brain injury, as well as a clinical article on acute presentation and management of strangulation. All of these are available on our website on that dedicated page for healthcare professionals. At the other end, to assist women accessing healthcare, we produced a medical referral letter. It's designed to help the woman communicate to a health professional any signs and symptoms she might be experiencing and the impacts that she feels the strangulation has had on her day-to-day functioning. The medical referral letter can be particularly useful for women that you suspect may have a brain injury, who might find the process of explaining what's going on stressful or challenging. The letter includes an area for service providers to explain to the healthcare professional any services they will continue to provide the woman. We found that doctors were more likely to spend appropriate time addressing the woman's physical needs, her head and neck injuries, if they knew that the service provider had her mental health needs and her safety planning sorted. The letter was also a way to help provide GPs who might not have seen somebody who's been strangled or sexually choked before resources like those clinical guidelines we mentioned earlier. We talked about this letter every time we spoke to the GPs so that they weren't surprised to receive one.
Okay, so let's return to Opal's story. So Opal lived in a rural area that had no brain injury services or appropriate allied health services available to her. So, how was she able to access free physiotherapy, free neurophysiology, and free occupational therapy, as well as counseling and case management? So Opal's town is home to Women's Health Northern Rivers. So when Emma Siegel, the manager of this Women's Health Centre, identified there was a gap in their referral pathway, she went on to apply for a separate grant to help fund brain injury and allied health services for local women who had experienced strangulation. She got those monies and the Pathways program was born. With this funding, Emma was able to get Opal and other clients the centre sees the help they needed, delivered in a place they already felt safe and comfortable. It didn't take long for Women's Health Northern Rivers to recognise that in addition to helping women access specialist health services, the impact of strangulation had also caused financial insecurity, and women needed support in navigating Australia's complex application process for disability supports. They created partnerships with local services who specialised in these applications to get the results women like Opal needed to live with their brain injuries caused by strangulation and other compounding violence. Going back to the 4 key areas our teams needed support in to improve women's outcomes, the next one is delivering health promotion. While our teams often had well-worn ways of conversing with women who had experienced domestic, family, and sexual violence, for many practitioners, taking a harm reduction approach to sexual choking was new. The referral pathways we built for strangulation and sexual choking both include instructions to deliver health promotion or psychosocial education to women, particularly in the absence of signs and symptoms of life-threatening injury that would see the women referred to a mainstream health setting. We covered effective health promotion approaches in the 3rd round of face-to-face training using role plays and simulations, which you can see practitioners engaging with in the photos on the screen here. We supplemented this face-to-face work by making a resource that sets out 8 evidence-based ways you could approach delivering health promotion to different audiences of people who are currently engaging in or maybe considering engaging in sexual choking. This resource, which includes practitioner examples, is available on our website. You will also find teaching tools like the graphic showing the visible signs of sexual choking, which can be used to encourage help-seeking behaviour by helping clients understand the visible signs can mean a more serious event has occurred. There's a short digital story for women where medical practitioners explain what happens in the body when you are strangled, which can help the woman understand the seriousness of strangulation, even in the absence of visible signs.
Brain injury was one area where we had to do some additional work to support our teams to deliver effective health promotion. In addition to that lack of accessible, affordable, and acceptable brain injury services for women, there was also a lack of information available for women that addressed both the brain injury and the violent domestic context in which it occurred. We explained to our teams that even when there is a service gap, it's important that women are given information about brain injuries to potentially understand and make decisions about their own health. Understanding that you might have a brain injury can be powerful, even when it's not connected to engaging with a medical response. It might mean you finally understand what's happening in your body, you stop feeling crazy, and you forgive yourself for not having the executive function needed to plan to leave a violent relationship without help. We address the needs of women and the practitioners working with them by creating a pair of resources: the Recovering from Brain Injury booklet for women and an accompanying practitioner guide. The guide includes conversation starters that help practitioners create opportunities to hand women the booklet and ways to discuss and tailor brain injury health advice to what might work best in her individual situation, particularly if she's still living with the perpetrator of violent abuse. One way that we supported our teams to make a better response to women who might have a brain injury was by running an event called Women, Violence and Brain Injury. It included a range of speakers, some of whom will be no strangers to you in the ENIGMA group. Each of the speakers, including Karen Mason and Dr. Paul Van Donkelaar from Canada's SOAR project, who happened to be in Sydney at the time, helped our teams understand the role that giving women information about brain injury can play in their recovery. One of the speakers had lived experience of having a brain injury diagnosed in the Australian medical system. She was particularly well received by our audience, who left with our resources in hand, ready to talk to women who screened positive for strangulation about it being a mechanism of injury for brain injury.
So our final area for driving practice change to improve women's outcomes relates to data collection. When we created our evidence brief, we found key gaps in data about women's experiences of strangulation, sexual choking, and brain injury. More data relevant to the Australian population will help us identify at-risk groups among our communities. More data will see state-based health organisations like New South Wales Health refine clinical protocols relating to when an MRI or other medical imaging is necessary after strangulation. More data will help us advocate for improved access to brain injury services where none exist. Within our network of women's health centres, we reformed the way we collected data on these issues. In July this year, we received the first collection of data that covered a 3-month period. Data from 11 women's health centres showed screening for strangulation occurred 452 times. So that's 41 times per centre. Positive screens resulted in further assessments on 275 occasions, or 25 times per centre. Positive screening for strangulation sits between 7 and 81% in completed reports. For example, in one rural women's health centre that screened 122 clients, 7% or 8 of those screened disclosed strangulation. In another rural women's health centre that screened just 21 clients, 81% or 17 clients screened positive. In our annual report data, we also saw a significant increase in the number of occasions brain injury was recorded as a presenting issue. So, for example, in the 2024 financial year, brain injury was recorded as a presenting issue on 126 occasions by 6 women's health centres. In the 2000 and latest financial year, a brain injury was recorded as a presenting issue on 305 occasions from 9 different women's health centres, which is more than double of that from the previous year. This reflects an increase in awareness of brain injury by service providers who are now actively engaging in conversations about brain injury with women. From even this small amount of data, we can see the Pathways project has driven practice change, and we anticipate next year's data to show an even bigger change, particularly in recognising brain injury because of the event Jackie just mentioned, which consolidated these learnings, and it took place after the data was gathered. So while this Women's Health New South Wales project concluded on the 31st of July, we are still working with Women's Health New South Wales on workforce capacity building initiatives and are very happy to chat about this project. By working together, we hope to ensure that there's no wrong door for women experiencing strangulation, sexual choking, and brain injury, and that women's holistic needs are being met when they choose to disclose these experiences to us anywhere in the world. And that's all we have.
Thank you so much, Courtney and Jackie. That was a fabulous talk and such an interesting program you've developed. A couple comments in the chat about you guys being ahead of the curve and ahead of the times in terms of responding to, in particular, sexual choking. So thank you very much. While we wait for people to add their questions and comments into the chat, I was wondering, you said that when you did the education components, you had the 3-minute video, a podcast, an article, and I actually forgot the 4th one. But I was wondering what you found most effective in terms of an educational approach.
So if we're talking an educational approach, particularly for our GP, so our family doctors, um, the most effective would have been engaging with those with health ed and those podcasts. And the reason for that is because health ed had a pre-existing audience that was quite committed to using that platform in order to gain their CPD points. So it recognizes their CPD points, which was an encouragement. It also meant that they could listen to those podcasts on their way home. And so it worked with the chaos of a GP's schedule. Jackie, did you have anything to add to that?
It's really difficult because we did a lot of top-down work with our state-based health organisation, and that was super useful. And they fed in, and we know that they're now developing clinical guidelines for sexual choking. So the project really like stirred some top-down work that was really helpful. But at the other end, all of our state is divided into primary health networks who manage GPs, and it's taken longer to filter down to them, but they're now booking us to talk to their GPs. So the more times we got to talk directly to GPs about what this is going to look like, what questions you could ask the woman, how you might go about that. I think direct talking to GPs is the best way to go.
Um, Maybe as a follow-up question in the chat, Karen Mason asked, how responsive have physicians been to this approach?
I think they've been really responsive. They've been really grateful to have ways and times of when to broach this. Like, so for example, if you're doing a sexual health check, this might be a good time to say, hey, is there any sexual practices that, that you've been worried about? Some of my other patients tell me sexual choking's on the rise. Has that been coming up for you? So I think having the language has really assisted GPs, like all the other service providers that we worked with. We have had a bit of pushback on the way that the Australian medical system pays for consultation time. Like, strangulation is a complex presentation. It requires quite a lot of work at a GP. And so we tried to sort of support GPs with that by drawing attention to a consultation level E, which is an hour to do complex issues. But I think it's, if you can get 5 patients through on a 15-minute time slot, you still make more money than you would on one longer time slot. So we do have some structural issues with addressing women's needs.
I think I might just, Kelly, I might just add one thing to that, is that we found GPs felt more comfortable in responding to women who'd experienced violence when we utilized the medical referral letter, because it told them that the organization referring the woman in was already taking care of her psychosocial needs. So her safety and mental health was already cared for, and she was really just going to a GP for that head and neck injury. And I think that allowed GPs to go, okay, I'm within a space that I'm comfortable and familiar with. And then through that engagement with the women's health centres, the GP could also build their own skills in responding to violence as well. So I think that was quite helpful. And GPs like to be prepared as well. So in where possible and where safe to do so, and obviously approval with the woman, you'd send that referral letter ahead of her so the GP can go, oh, this is what I'm seeing next. So if they're not familiar, they can use the guidelines that are linked in that referral letter as well.
Thank you. There's one question here in the Q&A asking, first, thank you for a great presentation, and then wondering if the TBI rehabilitation programs are linked into your referral pathways.
Do you want me to answer this? So in Australia, which is like most countries, there is a really big gap when it comes to rehabilitation services, particularly when we're looking at that mild and moderate brain injury, because of the stress on the services to respond and rehabilitate the more serious brain injuries. Often the women we work with, there is very few or no pathways for them. So like in the case study that we shared today, Women's Health Northern Rivers had to essentially create their own pathway. They had to go out and find professionals that would then come and work at their centre to respond to these women. So in terms of that, yes, it was a big focus of what we wanted in our referral pathway, but we were finding workarounds in order to do that, because our healthcare system isn't quite there yet when it comes to that. Jackie, did you have anything else to add? Yep.
I mean, we did. Okay, I do. We found that some of those services were just not particularly appropriate for women, because as they walked into them, they had big photographs of sportsmen up on the walls, and they looked like the perpetrators. So I guess. And we looked at an app with a researcher to go, would this be useful for our women? And all the language, when it's okay to return to play, like this is not play. Like we really struggled with what was out there and connecting this group of women to it in a way that was meaningful and that met their needs.
Thank you. We have another question in the chat here asking, are these terms using for education about choking, play, and sex? I've seen sex education or educators in Los Angeles addressing sexual choking in these terms, the dangerous air choke, blood choke, and instead use fantasy choke, only using the jaw and not touching the neck.
Yeah, we did. We didn't hear those three terms, so they might be regionally specific. But we did cover a whole lot of a whole lot of education about sexual choking, and we talked about where you get your information from. We had some legislative issues, like we looked at different states' legislation, and we had a perpetrator in one state but he was only doing a blood choke, and the legislation specifically said block airways. So he used that to try to say that his behaviour was not covered by the legislation. But we definitely in our education tried to talk about the different ways and the perception that these activities were safe, and the misinformation, and getting your information from an appropriate source.
Thank you. You mentioned very briefly about getting the funding to do this. Could you elaborate on what that was and what kind of advocacy work was involved, and inspire the rest of us to try and get funding for similar programs?
It's a limited grant program that was designed to address sexual violence, which we expanded, as we said, considerably in what we ended up doing. Unfortunately, that grant program is now finished, but all of the projects, there was 14 projects in it, and they all addressed different niche areas of sexual violence. And together, we're looking forward to the final report from all of them, because together it will be quite a nice blueprint for how we can make some changes to address sexual violence. I think the government's interest in what they learned from delivering these projects was that 2 years was too short. So hopefully the next round of grants gives you a little bit more scope, because we're definitely not finished with what we'd like to do with strangulation and sexual choking and brain injury here.
Practice change takes longer than 2 years, right? You need to consolidate learning, and yeah, it's a difficult one.
Absolutely. All right. I think that is about it for the specific questions. There's one comment asking if you have spoken to Debbie Herbenek, or I'm not sure how to pronounce, but experts in the US that work on sexual strangulation.
We were super chuffed to reach out to Professor Herbenick and have her respond and share our resources in the stuff that she was doing. It was a really powerful connection, and it definitely informed how we educated about sexual choking. Her research with men who engage in sexual choking that really found they didn't look up the safety implications of it at all. Like, they knew it could cause death, but then they didn't do anything about that. And also that sort of insecurity. So we ended up making a video for men who use violence with a men's behaviour change practitioner. And we really tried to kind of go, oh, there's some misconceptions, you know, and it definitely came directly from her work about we wanted to talk directly to men who are putting their hands on women's necks and go, actually, have you thought about this? Have you thought about what it's going to be like to explain to her family that she has a permanent brain injury? Have you thought about the likelihood that she may pee or lose bowel control during sex? And, you know, we found that there were some really kind of visceral reactions from the men to that, like, oh, like they didn't want that to happen. So I guess it was exciting to talk to Professor Herbenick and to try to put her research into action in what we did here.
Thanks so much. Sounds like some great collaboration opportunities going forward there too, between the US and Australia. All right, at this point, I'm going to turn it over for closing remarks, and thank you very much for your presentation and all around just a fabulous 2 days.